occasional shoulders. So that's my background. I haven't got any program or anything. So who is the first presenter?
The program is not with you, is it?
No.
Program is open to where?
At least I can call the first speaker.
इसमें तो नजर भी नहीं पड़ेगा. Proper copy.
Okay.
This is so.
No. Dr. Madan Mohan Thiruvengada. That's you? At least we have one. And you are supposed to be 9:14. So it's already passed. If you want to go ahead and start presenting. Yeah. No. It's ridiculous.
Loud voice where the previous singers, yeah? Okay, fine, good then. Hello, yeah. By the way, I'm Madan Thiruvengada. Let me introduce myself. I've been working in UK for about 10-15 years now. I was trained in Chennai. I did my diploma in orthopedics and then went on going my fellowships and doing training in UK. And mostly I specialize in sports injury, and I also do joints and upper limb surgeries as well, but my main interest in sports and upper limb surgery. But how I got involved in lower limb arthroplasty as well with my colleague, who is Richard Fernandez. With this, we brought up a new method, especially in NHS. We got a long wait list. So in order to reduce the waiting list as well as to get a better results post-operatively and reduction of the cost effective, we formulated this method, which is called as an enhanced recovery system. It is not a new one because it's been adopted in various surgeries as well, and possibly it's been developed by one of the, what's the next slide? Sorry, yeah. It's described as a new approach in orthopedics. However, it's been described in Denmark by Henrik Kelvet, who is a colorectal surgeon himself, and he's the one who first pioneered this system or method, whatever you call it as, in order to reduce the waiting list period of the patient, so while they get admitted to hospital and the discharge as well, and then on the care plan and also the cost-effective methods, which was described in the Lancet journal. This is basically a multimodal approach. It involves various specialty. The key person is a surgeon, of course, and also the anesthetist, physiotherapists, nurses, and a nutritionist. This is a gross pathway which I got it from the Department of Health, and this has been adopted by Department of Health as well in NHS. As you know, it jumps from one stage to another. In UK, it's been mostly the GP refers the patients to the hospital where we see the patients and being assessed, and then once the patient is put on the list, and then we do have pre-op assessments, and it goes to various stages. To be on a bullet points, I just brought out these key points where on this system method itself, the key points on this system is, or what we call as a method is, to reduction of the opioid-free analgesics, where the patients are more active in mobilization, and they are more, and then in minimization of the preoperative blood loss, where we can minimize the transfusion. That is also resulted in delayed in discharge and cost as well. And perioperative local anesthesia infiltration, where will be my key topic on this. We'll be concentrating on local anesthetic on infiltrations, and also post-operative opioids, which were minimized by doing this procedure, where they can get a good analgesics, and they are for early post-operative mobilization, which help them. So focused on this, our aim was, as I already mentioned, to compare the one which adopted this new system and the one which we were doing previously, on how it's very cost effective, and also the length of stay as well, how it has reduced it. Our methodology, what we adopted is a prospective cohort study and compared between the two groups. A group A we divided into, prior to this enhanced recovery method, and group B after this method. So we divided 2 groups, and each group we had about 100 patients with a consecutive knee replacement. I did include knee replacement, however we do hips as well, but to be minimizing on this, I'm concentrating on the knee replacement of patients as well for now. And we got a follow-up of about 6, I believe now we got more than 6 years as well now. So we standardized the protocol. So our pre-op protocol was every patient goes for a joint school educations, and some of them are aware of this joint school education where the surgeon, nurses, physiotherapist, and the patient who already had the surgery, they all meet together and have a discussion, and then we got a plan, and then do like a schooling and education for about 1 or 2 hours sitting with the patients, and then various queries has been answered in the education school where the patient is more actively involved in this. And then the health and risk assessment is made, and following this, the patients are optimized, and all the patients are get an informed decision making based on the school they attend, and various assessments done as well. The main thing is to avoid sedative if they're on any pre-medication medications on sedatives as well. And during the procedure itself, obviously, this is a more of a anesthetic point of view where they optimize the patients in fluid and hydration as well, especially on elderly patients. And most of the time we avoid sedative anesthetic, and then they give tranexamic acid at inductions, which has reduced considerably on a post-operative bleed as well as brought down on the post-operative transfusion as well. The most anesthetic they get is epidural or spinal or regional, and we got a good trained anesthetic where they can get a unilateral block as well. And also they do a controlled hypotension during the procedure. And my active role involves when we give this local infiltration, which we constitute about 30 mils of 0.5% chirocane, with 1 ml of 1 in 1,000 adrenaline made up to 150 mils with normal saline, and we divide it into 3 syringes of 50 mils each. And obviously we don't use any tourniquets. Post-operative, there is no drain, and we encourage on early oral hydration and nutrition. That's where the less sedative anesthetic as well as non-opioid analgesics helps, where the patient is more active to get oral hydration as well. And also regular oral analgesics, and again we avoid opioid-based analgesics post-operative as well as much as possible. And we also encourage on bowel movements by giving lactulose. And also active planned mobilization where our physiotherapists get more involved as well. The patients done in the morning with this, they have got a good pain relief, and we've seen patients mobilized by evening, and we encourage them. And if it's done late in the afternoon, we encourage them mobilization in the morning as well. So just to put it in a nutshell, basically a preoperative hydration and all those things, and then medications we concentrate on, and postoperative hydration and mobilization. So going into the technique as well, how we infiltrate local infiltration, as I told you, we divide into 3 syringes of 50 mils each. This is prepared by anesthetic himself, under standard procedure, and given to the nurse. And once we prepare the surfaces, we tend to infiltrate on the posterior capsule, and up to depth of 3 millimeter. And it's not a strict rule, go by right or left. So I usually practice from right to left infiltrating, so that I don't miss anything. Then then once the prosthesis is put in, and before the tourniquet, this is when I stopped using tourniquet. So I just got this one still on the slide, sorry for that. But nowadays we don't use tourniquet at all. I stopped using tourniquet for about 5 years now. And then we infiltrate about deep tissues around the medial and lateral collateral ligaments. And once it's done, then prior to skin closure, we infiltrate into subcutaneous tissue, where it's perpendicular to the incision of the skin edges. And this is where we stand about the results. With the average mean age of patients was about 70 to 72 years, starting from about 47 to 46 to going up to 89 years. The male was about 37 and 63 patients in the group A, and group B were about 20 and 30. The mean follow-up of about, we have about 21 months, and also after the system was introduced, we got a mean follow-up of about 18.2 months. As you can see, this has considerably reduced the average length of the stay from 7.16 days to 6.12 days. And the important point to note in this slide is we can see the discharge between 1 to 5 days, which has considerably increased from 37% to about 64%, and drastically in all levels of discharge, where it's between 6 to 10 days, it was about 26%, however. But up 10 days, it was about 10%. So most of the patients was discharged in 1 to 5 days. We've seen patients discharged on the next day as well. On conclusion, what we did find is it did improve quality of care, which obviously it involves the multimodal approach as well, and it reduced the length of stay. And moreover, it favored the independence of the patients while before discharge, so they were more independent and mobile rather than depending on our carers or so, which again costed the trust and just quite a lot of money. And this also decreased the nosocomial infections, obviously because of the reduced stay in the hospital, and there was also lower risk of thromboembolisms. Especially with the thromboembolism, I do believe that it could be resulted by when I stopped using the tunicase, which was one of the other studies we are doing, that comparing between tunicate and non-tunicate, and the other benefits of this system as reported in literature, or it reduced the mortality, which was done by Malvier et al. And the other thing is reduced cost effective, which we have found in our system as well. And then lack of post-op delirium, which we suppose because of non-usage of opioid analgesics. And what does the future hold? Whether we can do knee replacement as a day case, this is a debatable thing, and we are improving our standard. That's what, this is not our ultimate aim though. Thank you.
Thank you. Questions from audience? Keep it quiet, please. Few comments. Anecdotally, I can support all the findings in your study, because we started doing exactly what you are doing now. Your study was hip, was it?
Sorry?
Your study was on hips.
My study?
Yeah?
My study was on knees, as well as we do on hips as well.
Okay.
So my point of thing is tunicate. So why we stopped using is cementing or uncementing. So we don't use in hips.
Yeah, yeah.
So why do we use in knees?
Okay.
So there's been a lot of papers in literature as
Yeah.
well. Without the tunicate, the cement doesn't matter. I know.
Yeah.
That's the one, my point.
And secondly, we found that one of the hospitals had a rebound increase in readmissions. Did you find that? Some patients were sent home prematurely when they were not ready to go home, just because they were pain-free?
To be honest, we didn't find this in our study, and then I did do a literature search on this as well. But there were only few papers, but most of the papers, they didn't report on any rebound admissions after that as well. So I got few references as well, but on this one.
All right. Yep.
Of the 3 injections you are giving, right? But what is the rationality between giving after the placement of the component, acetabulum component and the femoral component? Why not together after doing the THR?
But only thing is,
Because
after putting the implant, you mean to say?
Why before the femoral component you are giving separately for the acetabulum side and the femoral side?
Okay. Let me go back to the slide. 1 minute.
Yeah, doesn't mean that the analgesic you are giving, local analgesic, means it effects last till its action is there.
Yeah.
In that, because during the surgery, you are giving the epidural anesthesia. Already the patient is induced there. Then what's the rationality between giving it 2 intervals at different times?
You mean local and the epidural?
Local, I'm just talking about the local. You are just giving the local infiltration. Yeah? You are giving 1 injection after acetabulum component is placed.
Yeah.
Second injection after femoral component is placed.
Yeah.
Why at different times?
I mean,
Okay.
To be,
If I may answer that, the simple rationale is if you are cementing the component, you are not doing anything while the cement is setting in. And that's the reason why anesthetic is injected at that time. There is no other reason, no rationale, no science behind it. And 5 minutes of difference here and there doesn't make any difference because you are talking post-operative analgesia.
Maybe the post, yeah.
So I don't think there is any science. That's what we are doing. But if you have different answer,
I do accept that.
so
I think that's
it's
what
just
it is.
you are
I
not doing
don't find
anything when
any
the cement is
rationale
setting. So you use that time to do something. Okay, so I think
there.
thanks for
Thank
that.
you. Thank you.
The next speaker. Do we have Dr. Saxena, Dr. Jain, Dr. Belur, or Dr. Kanian? Any of them? No. So next speaker is Dr. S. Rajkumar. Dr. Rajkumar is presenting on alignment and functional outcome following navigation assisted and conventional total knee replacement in Indian population.
Good morning to all. My topic is a prospective randomized study comparing the alignment of femoral and tibial component and functional outcome following navigation assisted and conventional total knee replacement. Total knee replacement is a cost-effective and efficacious treatment modality for severe osteoarthritis of knee joint. Computer-assisted systems have been developed to improve the positioning of processes. Our aims and objectives were to compare the alignment of femoral and tibial component in patient undergoing navigation assisted and conventional total knee replacement, and to compare the functional outcome following navigation assisted and conventional total knee replacement. It's a prospective randomized study, and 50 patients were recruited, and they were randomized into two groups. Group A patient underwent surgery by conventional jig-based method, and all adult patients with sufficient knee pathology to be appropriate candidate for total knee replacements were excluded from the study, and the patient age, sex, and site of the pathology and body mass index were noted, and clinical evaluation done by knee society score and WMAC score, and radiological evaluation by doing X-ray and CT scan. And knee society score consists of knee score and functional score. Each has a maximum score of 100. Here the higher the score, the better will be the function. And the WMAC score is a total score of 96, and here the higher the score, the worse will be the function. And the radiological evaluation done by standing scanogram from hip to ankle, and the X-ray of the knee, AP, lateral and skyline view, and the CT scan. And all the preoperative parameters in both the groups were comparable. There is no significant difference between the two groups. And as far as surgical techniques, the approach and the implant and the thromboprophylaxis and the antibiotic prophylaxis were standardized in both the groups, and the orthopilot scallop navigation machine is used in group B patient, and this is the imageless navigation system, and the patients were called to the OPD at the second week, third month and 6th month after the surgery, and these are the radiological parameters measured. And the frontofemoral angle is the angle between the mechanical axis of the femur and the intercondylar line, and the frontotibial angle is the angle between the mechanical axis of the tibia and the tibial condylar line. The normal value is 90 degree, that is 87 to 93 degree range, and the sagittofemoral angle is the posterior angle between the anatomical axis of the femur and the distal femoral cut, and the sagittal tibial angle is the posterior angle between the posterior cortex and the proximal tibial cut. And a mechanical axis, it's the straight line passing from the center of the hip to the center of the dome of the talus. Normally it passes through the middle 1/3 of the knee joint. And the femoral component rotation is the angle between the posterior condylar line and the surgical epicondylar axis. And coming to the results, and in both the groups, the frontofemoral angle is in the normal range between the 87 to the 93 degree, and there was no statistical significant difference between these two groups. And coming to the frontotibial angle, and again both the groups were in the normal range, and especially in the navigation group, patient were close to the 90 degree range, and there is a significant difference between these two groups. And coming to the sagittofemoral angle, except one patient in the conventional group, all the patients were in the normal range, and but there was no statistical significant difference between these two groups. And coming to the sagittal tibial angle, except one patient in the conventional group, and all the patients were in the normal range, and again there was no significant difference between these two groups. Coming to the femoral component rotation, and 7 out of 25 in group conventional group, and the 3 out of 25 in the navigation group had they were outliers of the normal range, that is more than 3-degree axial rotated, and this alignment is better aligned statistically in navigated group. And coming to the mechanical axis, and there were no outliers in both the groups, but there is a better alignment in the navigation assisted group, and if you see there is 88% of the patient were within 1 degree in navigation group, and only 48% the patient were in the within 1 degree in conventional group. And coming to summary of result, mean front of tibial angle and the femoral component rotation and the mechanical axis were significantly better aligned in the navigation group. And coming to the knee score, and in both group patient had postoperatively improvement in the score at the follow-up periods, and but there was no significant difference between the both groups. And again the functional score, both the group of patient had improvement in postoperative score, but without any significant difference. Coming to the OMAC score, and again the both group of patient had better score postoperatively without any significant difference. Our conclusion is the navigation assisted total knee replacement associated with improvement in the radiological alignment, but that is not correlating with functional outcome. There was a similar studies by in 2007 and in 2011 also, and these are the preoperative X-ray, preoperative scanogram, and this is how we measure. And thank you.
Thank you. Questions? What sort of instrumentation did you use on TBI, extramedullary or intramedullary?
Extramedullary. In femur also extramedullary. For
Femur intramedullary.
so for navigation it's extramedullary.
No, navigation it's all right, but when you use conventional TBI, intramedullary or extramedullary? Extra. Yeah. Okay. I think that's fairly standard outcome in many papers now. There is no difference. Okay. So shall we move on to the next one? Next speaker is Dr. Anil Reddy.
Good morning everyone. I am Dr. Anil Kumar, working as a consultant orthopedic surgeon at Hyderabad and Sunshine Hospitals. My topic for today's free paper session is functional assessment, assessing the functional outcome between the 3 types of procedures to doing bilateral total knee replacements, that is simultaneous, staggered and staged. This was studied done at Sunshine Hospitals under the guidance of my head of the department of orthopedics, Dr. A.V. Guruvareddy sir. Coming to why we choose to this study, ours is a high volume joint replacement center where we do around 2000 joint replacements per year, and most of them are bilateral. We advocate a lot of bilateral total knee replacements, whether simultaneous or staggered. So we chose to look into the literature if there is any significant functional outcome difference between the 3 groups, and we came across the literature with innumerable papers on comparison, but most we are seeing for either perioperative complications, post-operative complications, or the safety of the procedure, or mortality, or economic logistics as well. But not many papers did show us anything regarding functional outcome purely compared between all the 3 sort of procedures. Hence, as we advocate a lot of bilateral procedures, so we choose to look into the functional outcome in a retrospective study. Aim of the study was to assess and compare the functional outcome in between the three groups of post bilateral total knee arthroplasty patients attending outpatient follow-up clinic at Sunshine Hospitals during a period between August 2012 and February 2013. Materials were all the patients who underwent bilateral total knee arthroplasty at Sunshine Hospitals by a single senior orthopedic surgeon. Diagnosis other than osteoarthritis was excluded. Unilateral knee replacements, follow-up period which were less than 1 year, patients who were not willing to participate in the study, revision arthroplasties, infection and periprosthetic fractures, neuromuscular disorders, as well as patients with post-operative foot drop due to sometimes epidural injections or valgus corrections, and quadriceps rupture patients were excluded. The methodology, as I said, it's a retrospective study. Data was collected on outpatient basis at 1 year or later follow-up visits at the hospital. Data collected by a postgraduate orthopedic surgeon and data tabulated by a non-medical graduate. Parameters assessed were range of motion, pain visual analog score, WOMAC score and Oxford knee score, which are both very valid outcomes for function. Range of motion was assessed by the handheld goniometer with the orthopedic surgeon, and pain visual analog score was collected by a hardboard displayed to the patient in the outpatient department. The statistical analysis we used was analysis of variance for numeric variables in between the three groups, and if any categorical variables were there, that was compared by chi-square test. The study data during the 6-month period, we got around 848 knees for follow-up. Simultaneous group had around 203 patients with 406 knees. Staged group had around 162 patients with 324 knees, and staggered group had around 59 patients with 118 knees. This depicts the same details of the number of the patients as well as the male to female ratio. The only significant number among all these was around, in the simultaneous group, the age was significantly less compared to the other groups, which is expected because our guidelines to do simultaneous bilateral total knee arthroplasty involved age which was less than 65 years. The mean follow-up period was around 20.1 months, but there were patients ranging from follow-up of 12 months to around 127 months. Coming to our results, mean pain VAS score overall was around 0.044, which was not too much different from all the three groups. No patient had pain VAS score more than 3, but staged group showed 0.05, which was statistically insignificant though. Range of motion was almost similar. Simultaneous group had around 112 degrees of range of motion. Staged and staggered group had almost similar range of motion post surgery. WOMAC and Oxford knee scores, all the three groups appear to be similar, except the WOMAC stiffness score in staged group was less than 1, which was surprising to us as well compared to other groups. We expected simultaneous and staggered groups as well to be having less stiffness because they were operated in the same admission and they all went through the same physiotherapy protocol. Results, as I said, there was not significant difference in the range of motion, pain visual analog score or functional outcome. Coming to the deficiencies of our study, yeah, this is a retrospective study and there was selection bias in construction of the cohorts as we selected patients based on age, obesity, comorbidities and other aspects, and cohorts were not age matched as I have shown in the demographic data. This is a short-term follow-up within 1 year, so though some patients were there of long term, most of them were in early 1 year post-operative period. We did both CR and PS implants, so there is bias there as well. No uniformity of prosthesis because we use around 6 to 7 type of implants at our institute. We only assess the patients who attended the outpatient clinic, so we guess a lot of patients would have been missed as well from the study. Our strength of the study though was that it was a large number of subjects. All the patients were operated by a single surgeon. All the patients were operated with the same approach. Our rehabilitation protocol was exactly same for all the patients within the first weeks post surgery. Other similar studies we came across which compared the staged, staggered and simultaneous bilateral study was by done Foster et al. It was done in 2006, but the sample size was around 100 knees, though the results were almost similar to our paper. Though this study compares only early outcomes, we believe long-term outcomes to be same because there are not many factors which alter the functional outcome beyond 1 year except for the mechanical alignment. To conclude, functional outcome is similar among the 3 different cohorts and hence it should not be a valid parameter to advocate or deter a bilateral total knee replacement, simultaneous staggered. If there is no economic constraint or patient related demand, staged bilateral is safer and effective option rather than bilateral simultaneous or staggered because of the previous literature which shows lot of perioperative complications, though there was no level evidence regarding the perioperative complications as well. Thank you.
Thank you for that. Any questions?
Yes.
Could you tell us what is staggered and simultaneous?
Yeah. Simultaneous is during the single anesthetic episode, both knees done one by one, and staggered is within the same admission but within 3 to 7 days apart, sir.
And staged is something.
Staged is in different admissions, that is 6 weeks to whatever time apart it is, sir.
So actually, as per the definition, what you call simultaneous is not simultaneous; it is sequential. If you talk simultaneous, it means 2 operative teams.
Yeah, yes, sir. I looked into the literature. There was some confusion regarding that, but when I went to deeper, there was one more term called concurrent, sir. In the same admission, if 2 teams do operate, that is concurrent, and if 2 teams not, if one team operates one by one, it's simultaneous, sir. I went deep into the literature to actually clarify myself.
It's very clear in literature. 1 admission, 1 anesthesia,
Yeah.
2 operative teams operating together.
Yeah.
It is called simultaneous.
I think.
Okay.
Yeah,
Now,
thank you, sir.
When there are 1 surgeon, as in your case,
Yeah.
operating left knee,
Yeah.
someone is closing that and he is operating the right knee.
Yeah.
That is called sequential.
Yeah.
And staged or staggered, patient goes out of the theater and comes back, whether at the same admission or at the later admission after 3 months, is different issue altogether.
Yeah.
What we are really talking about here is the same anesthetic
Yeah.
and 2 surgical teams or 1 surgical team. So that's the whole thing that you need to be very clear. And literature is very clear about it. There is no confusion in that. There is no confusion. I don't know whether the people will agree. Yeah, that's right. So,
But I doubt when then what is concurrent, sir?
I think I'll just interrupt there. With regards to findings of this study, I think that's irrelevant because they are assessing mainly on the functional side. They were not looking into acute or short-term complications or anything like that. So how it was done in this particular paper is irrelevant. That's how I see it.
Yeah, I mean,
because they are assessing the functional outcome at 12 months.
discrepancy there, so that's what I thought.
No, I agree. We could debate this all day, but
Yes.
I don't think that's relevant to the outcome of this paper. One comment.
Same approach in all the patients, or 200 patients?
Yeah.
Which approach do you use?
Median parapatellar approach.
Okay. This is quite hot topic in world literature at the moment, but the main focus around the world is it cost effective and is there any perioperative morbidity and mortality?
Yes, sir.
Did you look at that aspect at all when you
We
were doing?
did one more study where we did perioperative complications and mortality as well, sir. We didn't find difference, but as I said, there is selection bias because we could not prospectively randomize because of the obviousness of that we couldn't include patients who are higher than 65 years into the simultaneous group or staggered. Because we couldn't randomize, we couldn't have a level 11 and evidence. Most of our study is also level 3 evidence, sir.
Is it possible that those patients who are already dead, they didn't attend your outpatient and that's why you didn't have any complications?
No, sir. At least the percentage of attendance was very good in the immediate post-operative period. The attendance declined after 1 year or something like that, but not immediate post-operative.
Okay.
Going to adding on the points on bilateral.
Okay, use the mic, please.
Due to the complications on perioperative and postoperative mobility, regarding doing simultaneous bilateral knee, so we are using an intramedullary jig for preparing the femurs, but in the literature it's been reported, So use simultaneous too. There is a high rate of DVT and PE while you shut it on more pressurized. So it's got a high risk of patients subjecting to bilateral knee replacement. So that's why in NHS, I mean, in UK where we practice, previously used to do bilateral knee where it's a cost effective and a lot of money saving for the trust and all these things. Because of this perioperative post-operative mobility and also post-operative mobilization of the patient is much more difficult with total knee replacement bilaterally. So most of the trusts stopped doing this as a single stage procedure, to be honest. And this has been reported in literature as well. There's a high risk of perioperative and post-operative mobility.
Yes, sir. I've looked into the literature extensively regarding perioperative complications as well for one other study we were doing. But the best of the studies are still to level 2 evidence. There is still no level 1 evidence in all literature given. There was no prospective randomized study comparing bilateral staged, staggered or sequential, as sir said. There was no prospective randomization. All were with selection bias because I don't think it is ethical to randomize some patients beyond 65 into simultaneous groups. That's what I think.
It all comes down to stratifying the risk when you select the patients.
Yeah, if patients are selected, then the risks appear to be same in both the groups if patient selection is very careful.
What is the medical assessment before you put the patients for bilateral?
Yes, sir. There were few features, sir, we looked at. Some were surgery related and some were patient related. Patient related were mainly patient age, very obese patients and patient severity of pain, sir. Basically, how much they were suffering. Surgery related, we looked at comorbidities of we looked at the severity of the deformity and we looked at comorbidities of the patient and mainly cardiac risk also we looked at it, sir, after doing the abdomen stress echo, how it was.
That's what I'm asking specifically.
Yeah.
What did you do in cardiac evaluation?
We generally did routine, most of the patients went according to the routine cardiac evaluation with ECG and 2D echo and then cardiac consultation. If a cardiologist felt they required more evaluation, they asked for a dobutamine stress echo, sir. If dobutamine stress echo was negative, along with our other criterion that is patient less than 65 years of age and having severe pain in both the knees, then we went ahead and did the bilateral total knee replacement. But if dobutamine stress echo was positive, we never went ahead with the bilateral total knee replacements. I think one at a time. That too, if patient is understanding the risks, or else if dobutamine stress echo is positive, we actually advise the patient to go to cardiac department, get that sorted out why the stress echo is positive. Some patients went to angiogram, detected, went CABG and got back to us later.
Okay, I think that's enough. We have to wind up there. Thank you very much.
Yes, sir. Thank you.
The next speaker is Dr. Jay Shah. Dr. Shah is presenting comparison between spinal versus spinal and local infiltration protocol in total knee replacement.
Good morning, friends. My name is Dr. Jay Shah. My topic for today is comparison between spinal with local infiltration anesthesia versus continuous spinal epidural anesthesia for TKRs. Standard methods such as peripheral nerve blocks, epidural anesthesia or IV narcotics are used for the management of post-op pain. Each of these methods have their own side effects such as hypotension, muscular weakness, numbness, nausea, vomiting, etc. Local infiltration is considered to be is a new mean which is known to give satisfactory post-op pain relief in TKRs with rapid rehabilitation and very less side effects. Our hypothesis is that combining spinal anesthesia with local infiltration will lead to reduced postoperative pain and early rapid rehabilitation. We conducted a prospective randomized control trial at our institute where patients undergoing a single TKR, primary TKR for primary or secondary ONE between 35 to 80 years were a part of the study. Patients with contraindications to the study drugs or patients who had narcotic dependence were not a part of the study. 400 patients finally consented to the study and were randomized into two groups. The pre-op data was taken on these sheets. Group A got spinal anesthesia with local infiltration anesthesia. Group B received continuous spinal epidural anesthesia. Spinal anesthesia was given with 0.5% heavy bupivacaine with fentanyl. Local infiltration with 0.5% bupivacaine, 20 ml, 10 mg of morphine, 1.5 grams of cefuroxime, 300 micrograms of epinephrine, and 100 ml of normal saline. 80 ml was infiltrated into the soft tissues. 40 ml was into the subcutaneous tissues. Epidural was continued at about for up to 48 hours post-op at 8 ml per hour with 0.125% bupivacaine. All patients got 1 gram paracetamol TID from post-op day 1. Rescue medication was kept at 50 mg of tramadol if the patient's VAS score was more than 4. Assessment was done at 6, 24, 48 and 72 hours with these sheets. Our primary endpoints were pain on the VAS scale, rehab measures, and the amount of rescue medication used by these patients. We had a total of 382 patients in our study, with 193 in group A, 189 in group B. The pain on the VAS was significantly more in the group A patients only up to the first 24 hours, with the pain score being same after that on day 2 and day 3. Similarly, rescue medication was used more in group A patients only up to the first 24 hours. The walking distances, range of motion and straight leg raising tests were significantly higher in group A patients on all 3 days of the study, that's day 1, day 2 and day 3 till they went home. Total days in the hospital, we didn't find any significant, there was no significant difference between the two groups. The complications rates were more in group B up to 24 hours in most cases. Coming to the discussion, this study by Spreng et al. Has shown that the pain scores were higher in the local group only in the first few hours after the surgery. Similar studies were also there, but both the studies gave a second dose at 20 to 22 hours post-op. Our group A had more pain in the first 24 hours, but after that it was the same in both the groups. We gave only a single shot at the end of the surgery. Narcotic medication use was significantly higher in group A only up to the first 24 hours, and that was also the finding in the study by Spreng et al. The knee function was far better in the patients of group A. We believe this to be due to the rapid return of the power in the patients of group A. The same results were also found in these studies. This study by Kerr, Cohen et al. Also has shown that the infiltration block does not impede the muscle power. This study also shows that most of their patients went home after one night. We did not find any significant difference in our study, but more patients in our study in group A were ready to go home on day 3. The complications were more in group B, and this was the finding also in these studies by Spreng et al. And this study as well. In conclusion, I would like to say that the continuous spinal epidural anesthesia provides significantly better pain relief only up to the first 24 hours post-op, but associated with significantly slower rehab up to day 3. Spinal with local infiltration ensures satisfactory pain control and faster rehab of the patient. Thank you.
Thank you for that. Any questions?
Yeah.
I mean, the overall rationale of is not using the opioids.
Correct.
That's what.
Correct.
In your local infiltration, you added morphine.
We added morphine sulfate. Morphine, our main aim was to make sure that the patients don't get too much of the opioid drug post-operatively. So to ensure that the pain relief is there with the local infiltration, we introduced opioid as well. We went into the past studies and most of them have used some form of local anesthetic with an opioid in their studies.
You could be more specific in your wording, saying that systemic use of opioids
Systemic use of
post-operatively.
opioids was,
That would-
that's what you wanted to avoid.
Yeah, because I did a similar study as
Yeah.
we did. We've been using this, but a lot of the studies which we talked about, and then the whole point is not to use morphine, and then but there was no any studies comparing using morphine local and adrenaline and using just local and
No.
without using morphine. There's no any
there's
comparative
there's
study.
no comparative study on that.
But my point of saying is morphine, the whole point of this enhanced recovery method which we spoke about is not to use morphine based analgesics, which is improving the post-operative care and the rehabilitation as well. So that's what morphine doesn't make any difference on as a local infiltration using it, so as a pain
Yeah.
relief.
Right.
That's what
We have-
my point is.
We have
So
We have not
what
done
he's
it.
saying is, yeah, you can try not using morphine in your future
we have not
care
tried
patients.
that. I mean,
Yeah.
all our patients have got morphine in the local infiltration. So
And the simple explanation for why you have got those findings is pain relief works better before the induction of the stimulus. So when you had spinal in, that effect, first nociceptive stimulus was blocked by that spinal.
fine.
Whereas the patients who received only local anesthetic infiltration, they received it after you started cutting the skin.
Yeah.
And that makes a difference. So I have worked with surgeons who started injecting before they incise the skin, and they had better outcome as compared to surgeons who were infiltrating in the procedure, in the middle of the procedure.
We give it at the end always. So we have not.
Yeah, so that's the difference, why spinal patients had better outcome.
In your group A, with that 24 hours, first 24 hours when there was a lot of pain,
Right, sir.
we did similar studies in our center, and what we find useful is to give a the femoral nerve block
Yeah.
at the time of once the surgery is over, because first 24 hours
Yeah.
we don't mobilize the patient.
No.
So those patients do very well, and their requirement of opioid or any other analgesic becomes very, very minimal.
We don't give any
No.
blocks to our patients because we feel that the motor weakness that the patients have got that we have seen in the past cases is too much, and we would like to start our patients to move their knee actively by about 6-8 hours post-op. Within the first 24 hours we want to make them walk, so they are out of the bed, they are
Same evening.
taking a few steps or something on the
Same
first
day.
day. Yeah, same day.
Same day.
Same
Same
day.
day.
Same day.
Okay.
So that was our aim.
Yeah.
So
I must admit, yes, most of the centers have stopped using blocks for the same reason.
same reason.
Yeah.
Sir, to add to that, because I was there while the study was being designed. The morphine we added because we tried to do literature search. They said there were lesser number of opioid receptors in me, but the studies in the physiology literature showed that there were still endorphin receptors present in the posterior capsule of the knee. So we thought morphine would help relieve the pain in the posterior capsule. That's why we added local morphine.
Okay. But yeah, next paper you could try without morphine and present it next year. Yeah. Thanks. Okay, so the next speaker is Dr. Amit Singla.
Thank you.
Thank you. And Dr. Singla is presenting the embolic load after total knee replacement is a function of the, I haven't got the next part of the title.
Good morning, everyone. My topic for the today talk is the embolic load after total knee replacement is a function of tourniquet time. The cause of the embolus while doing the surgery perioperatively can be due to the intramedullary jigs which we use in conventional knee replacement, or it can be related to tourniquet use or the other reasons which are poorly understood. The effect of the embolus is on cardiopulmonary system as it increases the pulmonary artery wedge pressures, pulmonary artery pressures, which will in turn decrease the cardiac output and will cause tissue ischemia, or it can lead to central nervous system side effects like confusional states in post-operative period. The content of the embolus which comes while doing surgery is also debatable, that whether it is fat, cement, monomer, particle of the cement, or air, or thrombus. Now the previous studies which are done on the embolic load after knee replacement, the first study was in 1998, published in JBJS, done by Burman et al. They have shown that the that the showers come in all the surgeries after tunicate deflation, the echogenic showers seen on transesophageal echocardiography intraoperatively, and they have not found any association between the duration of the tunicate and the intensity of the showers. And they have seen that the showers are composed of thrombus, venous thrombus, and no fat was detected in their studies. In the latest study by Permet et al., they have shown that compared with the knee replacement without tunicate, tunicate use places patients at 5.3-fold greater risk of having a large embolus. Also, similar study done on arthroscopic surgeries, they have found that the acute pulmonary embolism may occur within 1 minute of tunicate release, and that the number of emboli is dependent on the tunicate time. Now recently there are studies which compare the embolus in computer assisted knee surgeries versus conventional knee replacement, and they have also variable results. In the study published in JBJS British by Kaliraja et al., they have shown that there is significant difference between the two groups with significantly reduced embolic load in computer assisted knee replacement as compared to conventional. Similar results were published by Church et al., but the different results of no significant difference between the two techniques are published recently in Journal of Arthroplasty. So, taking all this background into consideration, the aims of and objectives of our study is to study the relation of embolic score with tunicate time, body mass index of the patient, and the changes related to pulmonary artery wedge pressures which this embolic load will cause, and to compare the conventional and computer assisted surgeries with respect to embolic score, and to find out what is the content of the embolus. We did this study. This is a prospective randomized study done at Department of Orthopedic AIIMS. We enrolled 30 patients and we randomized them into two groups of computer assisted surgery and conventional surgery. The inclusion criteria were all the patients which are in ASA group 1 and 2 and which have sufficient pathology to be taken up for TKR, and the exclusion criteria were simultaneous hip and knee, simultaneous bilateral, and morbid obesity of more than 40 BMI. Other comorbidities which will hinder in the investigations which we done are also the exclusion criteria, and the patient who refused to give consent. We did intraoperative transesophageal echocardiography in all the patients. Pulmonary artery wedge pressures were monitored using pulmonary artery Schwann gas catheter. Arterial and right atrial blood samples were taken during the surgery and were evaluated for the emboli. Conventional surgery, we used extramedullary jig for the tibia, intramedullary for the femur, and we took all the precautions to decrease the embolic load, like the entry hole of the femoral canal was enlarged using the drill. The alignment rod which we put was fluted, the pulse lavage was done, and the suction catheter was introduced into the femoral canal to suck all the embolus so as to decrease the emboli in the conventional surgery. In computer assisted surgery, it was image free navigation system using infrared light tracking system we used. It was a Asculap system, and both the canals were not violated by the system. This is the orthopilot system which we used. Transesophageal echocardiography, this was done by cardiac anesthetist intraoperatively. We used Mayo Clinic score for evaluating the thrombus which comes while surgery. This is the score. This is the T probe which was inserted during the surgeries. The sample was taken, and the buffy coat of the sample after centrifugation was taken to evaluate for the fat. Oil red O stain was done to see for the fat, and the slides were evaluated by the pathologist blindly. These are how we make the slides. And pulmonary artery pressures were monitored using Schwann gas catheter. We monitored hemodynamic parameters as well as pulmonary artery pressures. These are the Schwann gas catheter. And we approached 42 patients. Out of them, some refused to give the consent for this invasive monitoring, and few were excluded because of anesthetic considerations. So 30 patients were recruited, which were randomized into two groups of conventional and navigation. We found that embolus appeared in all the patients after tunicate deflation, as we have done both the studies under tunicate only. So after tunicate release, we have seen embolus in both the groups, And while the tourniquet was in place, in the conventional group, when we insert the intramedullary rod, at that time also embolus was seen. These are two pictures of echocardiography intraoperatively. The first one is the baseline picture. This is right atrium, this is right ventricle. There is no embolus in the right atrium at the baseline, but this is intraoperative picture after tourniquet release. This is quite big size of embolus. The size is around 1 centimeter, which is considered to be significant by cardiologists. And this is also the other echocardiography photograph. These are the videos. Because of lack of time, I will not play. The results are that the maximum score after the tourniquet deflation we have noted down and compared. The emboli appeared after 15 to 20 seconds of the tourniquet deflation and were seen till whole duration of the recording. The average score was significantly more in the conventional group as compared to computer assisted group. These are the pathology slides where we have seen fat. These are the fat particles seen in very few previous studies. The fat was seen only in 3 patients of the conventional surgery, and the size of the fat was around 3 to 4 times the size of the neutrophil, which is around 12 to 15 micrometer. And the tourniquet time was significantly more in the computer assisted surgeries, which was around 55 minutes, and in the conventional it was 42 minutes. And the tourniquet, the relation of the tourniquet time with the embolic score was also significant in both the groups, and there was no relation of embolic score with the body mass index or the pulmonary wedge pressures. Also in the hemodynamics, the blood pressure fall in both the groups after the tourniquet release, but it was significantly more fall in the conventional group, but there was no other significant change in the hemodynamic or pulmonary artery parameters in both the groups. So the conclusion of our study is significant more embolic showers on transesophageal echocardiography in conventional knee replacement as compared to computer assisted surgery, and embolic load is directly dependent on the tourniquet time in both the groups. So it can be decreased by either using computer assisted surgeries or by decreasing the tourniquet time. And it is advised more in the patients who have more cardiopulmonary risk factors, like and who have more chances of getting deteriorated by the embolus intraoperatively or just postoperatively. Thank you.
Thank you. Any question? Probably one question, if anyone has. No? Okay, the only comment I would make is we know from tibial and femoral nailing studies that everyone gets embolus when you violate the medullary canal. It's good to have these findings, but it doesn't translate into clinically significant embolus. Every time you violate the medullary canal, they will get embolus, 96% of the time.
But we can decrease the embolus by using computer assisted surgeries, and in patients who are,
know that.
And the patients who have the marginal risk factors, who are more of getting, there are reports of intraoperative deaths or just previously when they used to violate both the canals, tibia and femur, and they do simultaneous bilateral. So
my question was, why did you do this study? What was the motivation when we already know all these findings?
No, because a lot of the studies nowadays are coming and they have variable results whether the computer assisted surgery has decreased embolic loads or not, and they don't have any consistent finding. So for that purpose, and also tourniquet, to decrease the time of the tourniquet use or to not to use it for that purpose.
Okay. All right. Shall we move on to the next one? Thanks for that. The next speaker is Dr. Kailash Patil. Do we have Dr. Kailash Patil? Dr. Patil is presenting on ankle alignment axis variation before and after knee arthroplasty.
Yep. Good morning, friends and senior colleagues. Much has been talked about the femorotibial axis correction during total knee arthroplasty, which is the main aim of doing a total knee basically. But what do we exactly do in a total knee is two basic things: is soft tissue balance and a realignment procedure. Two basic deformities, genu varum and genu valgum. Now conventional cuts, what does it align? It aligns the femorotibial axis, but a paper by Guchet et al. Has described two basic axes, that is the hip ankle mechanical axis and the hip ground mechanical axis. So in 2007, Lee described a ground mechanical axis as the better measure of limb alignment, as the axis of weight transmission is exactly from the hip to the ground. The hind foot alignment gives us a better a better perspective of the hip ground axis. Now, foot tibial angle or the distal tibio-calcaneal angle does not affect the conventional mechanical axis, but it does significantly affect the ground mechanical axis. Now, considering genu varum knees, heel valgus, do we find heel valgus in most of these knees? Yes. There were two papers by Busset and Suter that it does affect genu valgum knees, or genu valgum knees affects the alignment of the ankle. Now, how do we take this? The hind foot alignment is taken by the Kobe's view, and it is called as the distal tibio-calcaneal angle. Now, our hypothesis was there does exist a correlation between the knee and the ankle alignment in knee arthrosis, and totally arthroplasty corrects the knee alignment. However, in long-standing ankle deformities, it fails to correct post-operatively, which may affect the overall weight transmission axis of the limb with unequal pressure distribution on the implant itself as well as the ankle pain. Now, what we have hypothesized is in figure A, if you see, it's a normal knee with hip, knee and the ankle aligned well. In figure B, there is a varus knee with a heel valgus, or the distal tibio-calcaneal angle is in valgus. In figure C, if you see, the ankle, the hip and the knee are aligned well, whereas the ankle still remains in the same angle. Now, in JBJS 2005, there was a paper on plano-valgus foot. Does it affect posterior cruciate retaining or total knee arthroplasty? They have concluded that posterior tibial tendon insufficiency leads to a calcaneal valgus, which leads to failure of the implants. So, we had a prospective study with osteoarthritic knees and varus deformities from 10 to 30 degrees. We excluded the knees with fixed flexion deformities and BMI of more than 30, and extra-articular deformities were also excluded. We had about 30 subjects with mean age of 60. All patients were subjected to radiographs taken pre-surgery and 3 months post-surgery with a standing scano and a Kobe's angle. Now, this is how we took the measurement.